Hello and welcome to the podcast Infection Control Experts in Conversation, hosted by Inivos. The podcasts, with the help of national experts, aim to support IP&C teams in the real NHS world by offering advice and suggesting pragmatic solutions to drive down healthcare-associated infection. All evidence-based, of course. My name is Liz Waters, a recently retired consultant nurse with 22 years' experience in the IP&C world. I know how tough it is out there, having managed a range of IP&C issues in a very large health board. And so, to our third podcast, which focuses on surgical site infection, which clearly harms patients and costs the NHS considerable sums of money. COVID-19 diverted the IP&C world away from this important subject, but now that we are arguably in a better COVID position, it really is time to refocus our efforts. I'm joined today by Lilian Chiwera and Wendy Harrison, who bring a wealth of experience in the SSI arena, from the complexity of gathering outcome data to the development of national care pathways to prevent SSI. They will be sharing their expertise and insights into this important topic. We will also explore the role of theatre cleanliness in surgical site infection, a subject that has little attention, but is a crucial infection control component. But access to technology such as UV and HPV can give huge assurance that environmental pathogens are reduced to an absolute minimum. With a rapid turnaround of patients, technology needs to be quick and easy, and UV in particular can provide the solution. My journey with SSI began in 2006 as I was lucky enough to attend the Institute for Health Improvement Safer Patient Initiative 2, a national improvement programme attended by a large number of trusts. The initiative introduced huge numbers of healthcare workers to improvement methodology, focusing on a small number of patient safety issues. And one module focused entirely on surgical site infection. It all sounds rather basic now, but it was an enlightening moment at the time. We were introduced to a 4-item bundle: antibiotics within 1 hour of incision, no shaving, clipping instead, normothermia, and blood glucose control. IP&C teams across the country initiated the bundle, ensuring it was an owned project with surgical colleagues. But things have moved on, and I am delighted that Lilian Chiwera and Wendy Harrison have joined us today. They bring a wealth of experience in the SSI arena, from the complexity of gathering outcome data to the development of national care pathways to prevent SSI. Lilian and Wendy, welcome. It would be great if you could tell us a little bit about yourselves and your role in SSI. Wendy, would you like to kick off?
Hi, thanks, Liz. Yeah, my name's Wendy, and I have over 18 years experience with surgical site infections in Wales. So I work for Public Health Wales, and I am the lead for our national programme on SSIs. And as you said, Liz, we collect surveillance data around C-sections, orthopaedic procedures, and we've piloted colorectal surgery as well, and hopefully some vascular surgery. So we do have a suite of surveillance schemes, and we follow that up with interventional practice as well. So that's my kind of role in a nutshell.
Fabulous, thank you. I'm sure we're going to hear lots of interesting snippets about your SSI career as such. Lilian, how about you?
Hello, everyone. My name is Lilian Chiwera, and currently I'm working in Infection Control at Sherwood Forest NHS Foundation Trust. I do have a lot of experience in SSI surveillance and prevention. So have worked at Guy's and St. Thomas's from 2009 to 2022, where I helped to set up a very successful SSI surveillance and prevention service.
Fabulous, thank you both very much. I thought we would focus first and foremost on the complexity of gathering SSI surveillance data. I mean, basically, if we don't know what our rate of infection is, how can we know if we are improving? Wendy, can you tell us a bit about the challenges of surveillance in the world of C-section in particular? Because I know you did a very large piece of work around C-section pathways. Could you give us a bit more info about that?
Yeah, I can indeed. So we had a national programme which was mandated back in 2006, as you might remember, Liz, in Wales.
Thank you very much.
Yeah, we've had a challenging time. It took quite a few years to embed and to go through to, the interventional stages. So it was about 10 years, really. So just to summarise, we started about 21% the infection rate, and over that time we reduced it to about 3.5% the prevalence. So that's about a 73% reduction in the rates. And we talk about saving mothers from infection more now. So that's saving about 3,000 mothers from having an infection.
Wow.
And then, and putting a cost to it, it's probably around £10 million over the period. So the challenges that we had, I'll mention probably just about 4 of them. The main one was probably local ownership. And I think this is key to any surveillance scheme that we set up. We were lucky at the start that we had a very enthusiastic obstetrician on board. So he was able to get colleagues involved, help us with the form, and also look at risk factors. So as we went along for a couple of years, this was great. But unfortunately, he retired. And we found it really difficult to find anyone else who wanted to take on the challenge. But I think for C-sections in particular, we were lucky because we had midwives as well who were on board with us. And as you know, there's a lot of infections that are captured out in the community. And that's changed over the years because the discharge time has changed as well. So we kind of had to move the focus slightly. So the challenge was to move to looking more at our superficial infections rather than the deep-seated, because our obstetricians, not a sweeping statement, but not so interested in the superficial side of it, those types of infections. So we went with that. So I'd say local ownership has been difficult, and it is if you want your surgical colleagues on board. The second one is probably the post-discharge follow-up. It requires, again, engagement from the community midwives for C-sections, and it's a long follow-up. So we were looking at 30 days, and for a lot, you don't follow new mothers up to 30 days. I mean, we were lucky, probably getting to 21 days for a lot of our health boards. So we weren't kind of following up to the period that we wanted to for surveillance. And the other kind of issue was, how did we capture that data? So what we did was we actually sent a form out, so a post-discharge form with our kind of mothers, so that could be filled out by the community midwife. So I think that was a challenge in itself. So we've kind of moved on from that. We've cut it down to 14 days follow-up. We're not alone. Scotland follow up for 10 days post-surgery, and we validated that. So we're not missing a lot of infections. And in fact, we've got better quality data because we can be sure that those infections are actually related to the surgery.
Mm-hmm.
And then for the forms now, we have call them the purple pathways. So for post-discharge, there's these pathways that are then returned into the hospitals, and there's a section on there for updating the SSI status of the mother as well. So we're finding that that's working a bit better.
It sounds a fantastic piece of work, Wendy. Did you ever consider using health visitors at all? Because am I right in saying, I'm not a midwife, But am I right in saying that by law midwives have to go in for up to 10 days post delivery? But then is it the law that health visitors then have to step in for a little while? I was just wondering whether that was a consideration, or are you quite happy now that you reduced it down to 10 days post surgery?
Yeah, it is mainly up to about 10 days. You're right that we do still have up to 14 days that we've been able to have a follow-up up to those sort of times. Yeah, you're right, health visitors go in after that. And actually, if there's something obviously wrong with the baby as well, then you will have that community care carried on, and that's another way of following up to 14 days. Health visitors, we did think about that, but then again, it's kind of having to train them up around, you know, diagnosing infections, or them then having to speak with community midwives or the hospital. So we kind of, you know, kept it with our community midwives, and we felt that, you know, we were getting the information back there. And that leads me on really to the surveillance definitions. Again, any kind of clinical surveillance, it is difficult to get across the kind of definitions to our clinical staff. It's not a clinical diagnosis we're after, it's a clinical diagnosis, but it's for purposes of surveillance.
Yeah.
So, you know, an example would be looking at a wound infection. Then we're not asking for, I'd say, a junior doctor or a GP, etc., to actually make a decision on how they're going to treat that individual. It's more about, does it fit the criteria that we've set out for surveillance purposes, to say, well, that meets, you know, that definition. So for us, that was really difficult to make sure that all our community midwives were on board with that. And that will come later on if we discuss further, but we did actually put a training, kind of a training plan together around doing that later on.
Yeah, about what looks like a true SSI rather than just a colonisation.
Yes,
because that would inflate your SSI rates, wouldn't it? When in fact there was no need to include colonised wounds as such. But very tricky.
Yeah, it was, and I think that the challenge is how do you train? How do you train? What's the best way? So we did try various ways, and I think for us is a simple flow. So we had, I don't know if you remember, we had these A5 little booklets put together as well, and on there was just a little laminated flow, which you go yes, no. Do you meet this criteria? You know, have you got pus? Is it looking red? And that kind of thing. Have you taken a swab? You know, was there a micro result? So it was quite simple, and they loved those because they could put them in their handbags, they said to us. So that in itself was really good. And I would say pictures are really essential. It took us a long time to actually find good infected wounds, which is not nice, I know, but we did have some mothers who did consent, and that was really great. So we could show pictures in our training of, this is, you know, a wound that's healing nicely, whereas this one here, you know, 5 days in or 10 days in, this is something where, you know, you're thinking that is an infected wound. So I would say for any surveillance, you know, pictures are key, that is specific to what, you know, what you're surveying, rather than those gory ones that you can Google.
Yeah.
So the last thing would be feedback. So that's going right back to us at Public Health Wales and in our team, is timely feedback. So when and what we have had, I'd say, some criticism, but you can only report on what data you're getting in. So as you can imagine, if you're waiting quite a long time to get that data in, then we can't turn it around quick enough. So we developed a dashboard as well. So a good output, really. So your audience can look at that when they want to, and then they can make a judgment depending on when they've sent you the data in. And that's good feedback for them as well, because if they want better data or more up to date, then hopefully that will, help them to send it in. So I think that was the main challenges as well on that, and actually keeping them interested. So giving them the information on risk factors, showing them then some data where we have improved as well. So when we've had interventions, show them the graphs of the improvement and how many, like I said, mothers are saved from having an infection. Works really, really well on that. So yes, some really good work with our health boards, I would say, and you, Liz, as well.
I enjoyed every minute of it, and I recall going to I think you put a study day on in Cardiff, and I was just so impressed that there were midwives there rather than a whole pile of infection control nurses, because on a previous podcast we talked about ownership, and you'll only get that ownership from the clinical people who are on the ground. It can't be infection control teams who are just consistently banging the drum about this. Everybody's got to be involved and engaged. So I recall a really, really good study day. So you've mentioned quite a few challenges there, Wendy, and I suppose what strikes me is the amount of time it's taken to get where you are, but you are where you are now, and it's a great piece of work. Lilian, over to you. I know you did some fantastic surveillance work in Guy's and Thomas's, and it was around colorectal SSI, so I believe. Can you tell us a bit about the challenge of your surveillance, getting hold of your surveillance data?
Yes, indeed. Thank you very much, Liz. So where do I even begin? I think you've asked the question about colorectal surgery, but actually, as an organization, we were doing a lot of surveillance for various specialties, and I have to say, in 2009, when I was offered the job to be the surveillance team leader for the organization, I kind of say to myself, where do I even begin? And as you know, people kind of think that surgeons don't like to do surveillance, and that's what I was told. How are you going to progress this agenda, because you will never be able to get surgeons on board? But then I had to ask myself, why would surgeons not want to know whether or not their patients were developing surgical site infections? Surely we must be in this, to get the best for all our patients. And so before we even got to colorectal surgery, we started with cardiac surgery, where there were so many issues with surgical site infections at the time. And we were very fortunate because our surgeons were quite keen to make their required changes as well in practice to see things getting better for every one of us. So with those issues within cardiac surgery, patients were being readmitted with deep sternal wound infections. They had to go back to theaters, wash out debridements, application of negative pressure therapy dressings, increased length of stay. Of course, some patients were being cancelled for their operations. And that really was causing a lot of commotion for the bed managers, for the senior nursing leadership, and for the surgeons as well. So people agreed to come together, to work together and look at the SSI incidences. And so, apart from cardiac surgery, of course, we also did surveillance for colorectal surgery. We did cesarean section, like Wendy. Thank you very much, Wendy, for all the work that you've done in Wales. And we have done gynecology, we've done spinal surgery, of course, mandated orthopedics, for us here in England, and many other specialties that are too many to mention for this podcast. So I was involved in really coordinating, a lot of surveillance for a large acute organization in central London.
Wendy was fortunate enough to have midwives going in to patients' home post-op. But you don't have that luxury with all the other specialities. So how do you pick up the surveillance of potential surgical site infections after the patient's gone home in those other specialities? Because we all know in the NHS that we're discharging patients more quickly, and it must be a real challenge trying to pick up those infections that have happened at home. Can you give us a little bit of insight into that?
Yes, absolutely. So for all the surveillance that we're doing, including the cesarean section and colorectal surgery, C-section and colorectal surgery are the two specialties that we managed to do post-discharge surveillance. So we could pick up patients who developed infections after they had gone home. For colorectal surgery, we got some of our junior doctors to do a pilot for us. So they called all patients who had colorectal surgery for at 30 days for about 3 months to establish their SSI incidences. But at that time, our results didn't highlight that many colorectal patients developing SSIs after they went home. So we decided we were going to focus on the inpatient and readmission data. But for our cesarean section, when we started collecting this data, we were using surveillance forms, which we standardized to capture all the patient demographic data that was required for our surveillance, and of course, the SSI data. So the surveillance forms were being completed by the theatre teams when a patient had their cesarean section. And then after that, when the patient was on the postnatal ward, and also by the community midwives up to 10 days, they completed this SSI surveillance wound observation form that was eventually returned to the SSI surveillance team for review. And I know for Wendy and team, the post-discharge follow-up is up to about 10 days. But for us, we wanted to know more after 10 days. So we also send out questionnaires to women at day 25, which we posted. And then if we didn't get those questionnaires coming back, we would then follow up with a phone call. So again, to begin with, when we started this process, there were so many challenges. We were getting 7% of the questionnaires back, which wasn't good enough for us. So we knew that our data wasn't as accurate as it could be. So what I decided to do was, over a 3-month period, to actually call all C-sections that I could reach out to over 3 months, and then say to them, did you get a wound infection or not? And following the stipulated questionnaire with the definitions that would fulfill the Public Health England criteria. And what we found when I did that validation exercise is actually, whereas we had been reporting between 6 and 8% for our SSI incidences at the time, the rate with telephone follow-ups, went up to about 13%. So the telephone identified about 40% of the infections after discharge. But what was also interesting, again, when you think about, restricting that follow-up to 10 days, is for us, in the initial period, more than 55% of the infections had a time to SSI presentation more than 10 days. So if we had relied on our inpatient readmission surveillance and also the community midwives who follow up to 10 days, who would have missed up, the majority of the infections. So again, just kind of highlighting that, yes, perhaps if you agree to follow up to 10 days or 14 days, you may then need to do regular validations just to make sure that you're not missing anything. But having said that, we know that, resources are usually highlighted as a challenge for us to be able to do these things. But we've got digital transformation coming in now. There's so many technologies out there that we can, embrace and hopefully make this work better for us. And so it's something that we can certainly talk about, maybe, not fully today, but it may need another session for us to talk about digital transformation.
It certainly sounds like it, Lilian. I think there is definitely another podcast in the offing there. Lilian, I mentioned at the start of the podcast about the four-pronged bundle that was introduced by the Institute for Health Improvement back in 2006, and that's antibiotics within 1 hour pre-incision, normothermia, blood glucose control, and clipping if required, rather than shaving. Are there any other interventions that have come on board over and above that now that you have fully embraced in terms of an SSI pathway? And I've no doubt we'll come to you, Wendy, as well, that you've got some that are over and above that basic bundle. But do you have any, Lilian, that are worth mentioning?
Absolutely. So we have got recommended bundles for a lot of our surgical specialties, but actually, what we always say to people is, think locally. What our challenges locally, and also what are you experiencing during practice on the front line or in the community, and then tell us what else we can consider. So certainly for our C-section bundle, we had to look at NICE recommendations and made sure that we had those implemented as part of our governance pathways. Over and above that, we also then had to consider things like additional education for our community midwives around wound care. They highlighted to us that during their training, they don't get very much around, surgical wound care. So it's something that we had to sort of, do over and above everything else that we were doing. But certainly with the latest guidance from the WHO, there's a lot of emphasis around negative pressure therapy dressings for high-risk patients. So we also use those for our high-risk patients in cesarean section and other specialties. And that's certainly something that really has come to the light, in recent years, which wasn't sort of, very much recommended, in the early days when I started doing our surveillance. And we continue to really review any evidence that comes up, and then we explore that locally. And of course, the causative organisms for any surgical site infections are, something that we need to look, closely at and consider whether we need to do anything else, especially around, for cardiac surgery, for example. Do we need to do MSSA decolonization treatment for them? And of course, if someone has got MRSA, that is quite straightforward. We do manage them in line with established guidelines. But, for kind of going back to our C-section as well, we had to introduce vaginal cleansing in 2019, and certainly is something, again, that's being suggested that it can reduce the rates of deep organ space infections. But for us, during that time, we weren't getting that many. But, over the trial period, we didn't get any at all. So that was really encouraging. But I'll stop there and let Wendy say something as well if she's got anything to say about this item.
Yeah, what interventions over and above that four-pronged approach that the IHI used, Wendy, have you used for your C-section pathway or any other speciality pathway?
Yeah, going to the pathway that we've got is the pre-op phase, the intraoperative, and the post-op phase, as you were part of developing with us. That came out of that. I'd say the intraoperative, as you said, the four-prong approach. So we're still kind of following that, the WHO surgical checklist.
Yeah.
The surgeons for the C-section and other surgical specialties that we're looking at. I think the main change has been around the 2% chlorhexidine in alcohol. That's sort of swapped in and out, whether it's in alcohol or not, because of some of the obviously complications about using diathermy or any kind of heat around that. So we have included it in alcohol. That's the update. Importantly, though, is to actually let it air dry. I think that was something that we were trying to get across to the surgeons, because it's no good putting it on and then not letting it to allow it to dry. And then there was a lot of work around the application of it. Yeah. So without mentioning any companies, obviously there's some nice sponge applications going on. And again, I think the message is it doesn't matter how you're putting the application on, it is allowing it to dry, giving that time really for it.
What kind of time period are we talking about? Because I would imagine in the case of an emergency C-section that time is of the essence. So how long does it take for it to air dry properly?
I think probably because of the alcohol in it, you're looking at a ideally would be around 10 to 15 minutes.
Right.
But appreciating in an emergency that probably isn't the kind of, the waiting time that you want, but it's actually planning that you do actually put that application is on and who is doing that and how quickly that can be done. I would say on that. The other one is obviously the prophylactic antibiotics. Like you said, when we first began, it was that cord clamping. So we had a lot of challenges to ensure that it was given that 60 minutes prior to incision. So that's been a lot of work. And also the actual antibiotics, so the prophylactic antibiotics to cover particularly the C-section surgery. So we've got Welsh guidance on that it is cefuroxime and metronidazole, as long as you're not obviously allergic to those antibiotics. So that is the guidance on that. So we haven't moved too much away in that phase. I'd say there's been a lot of work, like Lilian said, around the pre-op and post-op phase.
Yeah.
Which forms part of the pathway, I would say. It's kind of part of our wound care and management training package that we developed. So it's got these kind of key requirements, and there's a lot of references in the pathway to that whole training package, which comes as e-learning, a local package for train the trainer kind of approach for new staff as well. So hopefully we get a standardized approach to preventing and actually recognising SSI. So that's what we wanted to do, but that's more for elective C-sections, obviously. So on the pre-op, I would say that the main kind of work was around the not shaving and not waxing.
Yes.
We're not just shaving, we're waxing as well now. So it was educating the patients not to do that. So we actually developed a sticker for
I
the
remember. I remember that one.
lovely
Yeah,
sticker.
yeah.
And it was also wash all your bits and bobs as well. So it was actually, you know, washing the groin, the peritoneum, etc., those areas, and any skin flaps for, you know, the 7 days prior to surgery. So the sticker was there for the midwives to remember to mention this information, and then it was in the patient's notes so they could see it. So it was more, you know, it was a nice pink sticker that we had. So that was one of the main ones, I would say, as well as obviously them having a wound care leaflet at that point at 34 weeks to say, you know, we want to get you to kind of consider aftercare, even though you haven't had your baby yet. So that was the main one. And I'd say post-op was, as Lilian mentioned, was educating the mother around, and the community midwives around, kind of looking after your wound.
Yeah.
We went against NICE guidance more recently because they say to remove the standard dressing after 24 hours, and there's a consensus from our steering group and with our midwives to leave it on for 48 hours. But as you know, Liz, there's a lot of dressings out there now. There's a lot going on, and it's difficult. So, you know, it's go with the manufacturer's kind of guidance, and whether it's negative pressure dressings or ones impregnated with, you know, the antibacterial, which are 5 days, that kind of thing. So it is quite difficult on that side. And the other,
the issue of having just so many dressings is that the midwives, you know, unsurprisingly, can just get very confused. So, is this dressing 7 days, or is it the 48-hour one, or is this one 8 days, or it must be quite difficult. I suppose if I was still in my infection control post, I'd be doing some kind of poster which lays out all the different dressings and being very clear how long each one needs to stay on. But I would imagine that would be very confusing for the midwives if there's such a choice of dressings. It must be quite tricky, I would have thought.
it is, and we are thinking of having a flow with the negative pressure dressings. We know where we are because of the BMI status. So, you know, for those with a higher BMI, you go down that kind of pathway of using them. So yeah, we're hoping to list them, but actually to standardise across Wales, there is a kind of shift to standardise what dressings that the health boards are using. So that's part of our next intervention. So that's going to be a big piece of work on that. And I think the education that we have had, which is around mothers not touching their wound, wearing loose fitting underwear, clothing, washing their hands. We've been quite successful. We had quite a few health boards who came together with their different leaflets and approaches, and we've got a recommendation, you know, have your local ones, but these are the points to include. So that's out there as well. And then educating the community midwives around, if you suspect a wound, again, going back to the pictures, this is what you're looking for. But then around how you swab a wound, you know, that way, as you remember, there's a lot of work around there. So in the pathway, it's about then having a look at your booklet, which will tell you how you should be swabbing it, having ANTT, so the can't even remember what it is now, aseptically non-touch technique. Bit of a mouthful there. So that's all in there, you know, and you can go and find out about that as well. And also moving away from the mother going to the GP as well, because we've had a lot of GPs prescribing antibiotics just to cover the mother, just in case. So it's saying to that community midwife, for you to own it, for you to make a judgment, then you can actually then, you know, recommend they go to a GP, or you can ask GP for antibiotics. And then we had a whole shift to almost all units, actually, all of our health board moving to the mother going back into the units, an assessment unit, and being assessed there.
Yeah.
So that's been really great. And then last but not least is that kind of important, once you have a diagnosis of an SSI, make sure you let us know. So fill in that form or a spreadsheet now we've moved to. So that's kind of our work that we've had interventionally, and there's still some more to do, but I think a lot of it is embedded. I'm hoping so.
Good. Well, it's never ending, really. You know, as soon as you resolve one issue, you're on to the next. But regardless, I mean, both of you've just done some absolutely fabulous work in taking this whole issue forward. And even if we just look at C-section alone, we've really got to take on board the misery that an infection causes to a mother who's trying to bond with her baby. As wonderful as motherhood is, I recall it being very, very stressful when, particularly with your first child and even with your second and subsequent children. So to have to cope with, an SSI, and when you're trying to bond with your baby, must be really, really difficult, indeed. Lilian, it is just fabulous that you are championing SSI on a national basis. I've seen your posts on Twitter, etc., and you clearly are passionate about taking SSI forward. Do you want to tell us a little bit more about it?
Yes, absolutely. Thank you, Liz. And of course, given all the work that I have done at Guy's and St. Thomas's over many years, and the successes and the reductions in avoidable SSIs that we demonstrated, I felt that we needed to give the opportunity for all patients wherever they are to have harm-free surgical care. So about April last year, which is 2022, we thought, why don't we have an annual SSI Prevention Day, which would be very similar to the annual Hand Hygiene Day, so we can try and elevate the profile of surgical site infections. So it all started with a tweet. And then, over the coming months, I used various social media platforms to ask, the world whether they thought this was a good idea. And it seemed like, everybody was ready for it. So eventually, we then decided to form a group, almost 200 people now on that.
Wow.
And just kept on communicating. What can we do? How can we make this work together? We did an abstract which we submitted to the Infection Prevention Society conference last year. We presented our proposals. They were very well accepted. And then came January this year, we had our inaugural meeting, very well received, and we have continued. So what is this all about then? So the SSI prevention group is newly formed and is global. We aim to raise the profile of surgical site infections to new heights by uniting many different healthcare professionals, patient groups, politicians, musicians, and everybody around the SSI prevention agenda, because we feel that over the years, even though we have got published data that actually, if you do things right, like the fabulous work that Wendy has been doing in Wales, it does make a difference. You do reduce the SSI incidence, but not much is happening. And of course, as we've already alluded to, people will tell you that they don't have the money for it. So our group then really aims not only to establish that annual SSI Prevention Day, but also to introduce some kind of regulatory style SSI prevention inspection tool that people can utilize in their own hospitals to measure whether people are actually complying with evidence-based SSI prevention measures implementation locally. And for that to happen, we have actually proposed an SSI prevention champion model, something that we used at Guy's and St. Thomas's, and it worked very, very well. So with this, we want to see every hospital having an SSI champion overall, and then perhaps they can have this, individual specialty champion as well, who will lead on the SSI agenda for their areas. And then when they do that locally, then they can feed to what we propose to be the regional SSI champions, and then up to the country SSI champions, and then up to the global level. So what we hope then will happen is eventually when we have that annual SSI Prevention Day, we will get our SSI champions coming in to tell us what's been happening in their hospitals locally. What are they doing to make a difference? What are they doing to start surveillance if they're not already doing it? If they're already doing surveillance, what are their challenges? What are the opportunities? What are the lessons that they can share with the global stage, so we can all do things and give all our patients, irrespective of where they are, that chance of actually getting harm-free surgical care. And so really, in summary, our proposals are aimed at achieving visibility and activism around SSI prevention, improved uptake of evidence-based SSI prevention recommendations in all settings, and also making sure that we've got dedicated and delegated responsibility for SSI prevention implementation signs in every organization. And once we have that, we hope then we'll be able to achieve those reductions in avoidable surgical site infections. And of course, again, like Liz, you mentioned, we can give that C-section mother the time they need to bond with their baby rather than worrying about an avoidable surgical site infection. And we can save money. And also, when you think about the global antimicrobial resistance challenges, when you prevent one surgical site infection, you're likely to prevent the collateral damage, kind of ranging from the AMR, maybe the cortis when, an SSI patient ends up with a urinary catheter, or those line bacteremias, when someone ends up needing, various lines, or sepsis even, if that wound is very bad and someone ends up in ITU and, on a ventilator. So there's a lot that we can do. And so we've come up with this mantra for our proposals: prevent one surgical site infection, prevent collateral damage. And that's kind of, what really is covering our proposals.
This is all about getting it right first time, isn't it? I recall the ward sister when I first qualified, who I still hold up on a pedestal now, and she used to say to us, get this right first time, because not only does it prevent all that harm to the patient, but you're not now having to go into a miserable patient in a single room who's feeling isolated and having to do all those dressings and give all those IV antibiotics. Absolutely get it right first time. And I truly think it's a wonderful piece of work that you're doing, highlighting SSI nationally and internationally, Lilian. So well done you. I have to say it is utterly brilliant. Just moving on for our final bit of the podcast. I'm scratching my head a little bit as to where theatre cleanliness fits into all of this. I recently read a study indicating that around 50% of surfaces in operating theatres are not adequately disinfected. For example, anaesthetic workstations have been found to be a source of pathogenic bacteria. I just find that truly worrying. The study went on to say that during surgery, the constant presence of personnel and door openings increased the number of aerosolized particles, likely causing a majority of SSIs. Do you both think that this is something that needs further attention in the SSI world? Do we need to start considering UV between cases? Because I understand it only takes 3 minutes. Or as a minimum, a deep clean and UV of theatres once weekly when they're not in use. Is it something that either of you have considered in your pathways, or is it something that really does need to be looked at and, if appropriate, pulled into any care pathways that you've got? Wendy, do you want to go first on that one?
I do, yeah, it is something we have considered, or I should say, I have considered, and we had an SSI conference last year. So I'm not sure if it's still available to look at the talks, but we had some really interesting talks in the afternoon around theatre practice and theatre cleanliness, and that's an area that we would like to explore with our IP&C colleagues actually in Wales, because you're right, I think the kind of throughput, people in and out of theatre, we've known that does contribute to the cleanliness of the theatres. There's quite a few studies happening at the moment. One in particular is called you can take this one away, just type in cheetah, it's called, and that one's around changing gloves and instruments for closure work. And I think the gloves is a kind of, you remember to do that, change your gloves, but it's the instruments. And Liz, there's a lot of studies out there about instruments becoming contaminated by the end before you are using them for closure.
Yeah.
Because again, the cleanliness of the theatres, but also that the instruments themselves are not actually positioned right under where the patients are actually being operated on. So they're actually outside of that kind of the laminar flow area, which is, keeping the environment clean. So yeah, absolutely, that's our next big piece of work in Wales, is to look into that.
Fabulous. As I said earlier, you resolve one issue and then you're on to the next one. But that's the nature of healthcare, really. Lilian, has this fallen on your radar at all?
Yeah, absolutely. And I have to say, a lot of the times, I think people end up just looking at what's published, what does the evidence say, but what we also know is there's a lot of good work that people are doing locally that they just don't publish. And certainly I would not be thinking SSI prevention without thinking the environment where that patient is going to have their procedure done. And not only that, even after they've had surgery, they are on the ward, what's happening when that patient is having their, wound dressing done, and what's in the environment.
Absolutely.
When that's being done. So for me, the environment is an area where we still need to do a lot of work around. And certainly from my experiences, we did a lot of work within the operating room, starting from, actually finding that in some places there were areas where there was dust, there was a lot of clutter, and so there were some difficult to reach areas which weren't being cleaned properly at the time. And also some of the operating rooms were a bit older. And then so again, in those situations, just relying on the usual stuff that you normally do would not work for you. So people would need to think outside of the box. So a lot of the work that we did around the environment was, certainly to do the decluttering, designing the theatre cleanliness checklist, and also making sure that actually the cleans were done in line with what we expected, and considering any other technologies. And certainly UV is a good one, to look at, and whether we want to do it between cases or we want to do that weekly. I certainly look forward to having evaluations being done in the area. And even with our work that we're promoting with the SSI Prevention Initiatives agenda, really we are trying to bring everyone in. So we are going to want to have those environmental experts, or the theatre environment, the ventilation and everything that comes with it, to be part of the bigger group. So we may actually have a stream focusing on the theatre environment, and then we can look at what evidence is available and what research perhaps we still need to do. And so yeah, definitely I would be looking forward to seeing more of that being looked into in the future.
I just think this is just so important. Anyone who knows me well will realise that I've been promoting and banging the drum about proper ward decant deep cleans for many years. I mean, it just truly astonishes me that most people will spring clean their house, once a year, yet we're not doing that in the hospital environment or the clinical environment. And yet we've got so much evidence to say that our environments are contaminated with all sorts of pathogens. And I fully appreciate the challenges around creating a patient-free environment, but the benefits are just tremendous. Not only are you deep cleaning the environment and either HPVing or UVing as such, you're able to inspect the equipment, you're able to unzip the mattresses and make sure there isn't a house of horrors going on inside the mattress. And of course, you can get all that essential maintenance done as well in a patient-free environment. But I'll get off my my soapbox on that one. It's something I'm very passionate about. Lilian and Wendy, thank you so much for your contribution. It is fantastic to see SSI getting the attention it deserves when you consider the misery and the harm it can give to patients, never mind the cost to the NHS, which must be considerable. Just to sum up then, I hope this podcast has given you food for thought. It's clear that the NHS is still under unprecedented stress, and keeping patients safe from healthcare associated infection is ever more challenging. Remember, it's important that IP&C teams do not shoulder infection control responsibility alone. IP&C is an organisational responsibility, and if anybody needs support with all those important exec papers, then just shout. Inivos can help. And don't forget that Inivos can also support you with your UV and HPV cleans in the theatre environment or in outbreak situations. Just give them a call. So Wendy and Lilian, thank you so much. It was great catching up with you both, and I really look forward to seeing how your work progresses. Thank you so much.
Thanks, Liz. Thank you.
Thank you, Liz. Thank you, Wendy.